My name is Jeffrey Spivak. I'm an orthopedic spinal surgeon at the NYU Langone Hospital for Joint Diseases. We know from much prior study that radiographic and clinical adjacent level degeneration surrounding spinal fusions in the neck is a significant problem. And the goal of artificial disc replacement, one of the goals at least, is to see if in the long term there can be a lessening of the overall radiographic degeneration and therefore potentially leading to less clinical degenerative disease of the cervical spine as well. So our goal was to look at that at the long term utilizing the ProDisc Cervical Artificial Disc Replacement IDE study database. Well, we looked at the artificial disc replacements and compared them to the control group, which was the anterior cervical discectomy and fusion patients. We looked at the data set from the FDA IDE study and looked at it in a post hoc way, analyzing the patients for their radiographic degeneration. And this was measured by outside independent radiologists utilizing a scale of degeneration from the radiographs called the Kellgren-Lawrence classification. And that's a classification where essentially grade 1 through grade 4 ranges from no to severe disc degeneration. And so we were able to look at both preoperatively and at long-term follow-up the amount of adjacent level degeneration, and therefore could see if there was any progression of degeneration of the levels above and below either the disc replacement or the spinal fusion group. Yes, first we found a statistically significant difference between the rates overall of radiographic degeneration when looking at either level, the upper or lower level, following disc replacement as compared to spinal fusion. The rates are high in all, probably because of generalized degenerative disease of the spine, but from 53% in the disc replacement group, it was as high as 77% overall in the fusion group. When we looked at that separately, looking at both the superior and inferior adjacent levels, we found statistical significance only in the superior adjacent level. The inferior levels did show a difference, but it was not statistically significant. We looked at not only the amount of degeneration and rate of degeneration in disc replacement versus fusion patients, but we also took the disc replacement patients separately and analyzed them relative to the radiographic degeneration at long-term follow-up, whether they had low mobility discs, which we defined as 0 to 3 degrees of range of motion, mild mid-mobility 4 to 6 degrees, and high mobility 7 or greater degrees range of motion. And we found a strong trend looking at this, seeing that in the higher mobility patients there was a definite trend toward less overall radiographic degeneration progression as compared to the stiffer discs, which acted more like the fusion patients. In addition, when we looked at not only the rate of progressive degeneration, but broke that down into the severity of the radiographic degeneration, whether progression was 1 grade, 2 grades, 3 grades, or 4 grades, we did see a very statistically significant difference in that the more mobile disc replacement patients had not only a lower rate of overall degeneration, but a much less severity scores in terms of the amount of degeneration as compared to the stiffer 0 to 3 degree counterparts. I think, in fact, it's the opposite, because we're concerned in fusions, which is the ultimate rigid construct of too much pressure on the discs above and the disc below, causing accelerated amounts of radiographic degeneration. In fact, we showed that the stiffer discs, 0 to 3 degrees, acted more like a fusion, but the more mobile discs, which is what we try to attain at surgery, did have a protective effect overall toward the rate and severity of the adjacent segment degeneration. I think that the main thing is this is really the first study that's looked at this and really was able to correlate differences in the radiographic degeneration rates and severity with the overall mobility of a disc replacement device at final follow-up.